You know, dry eye disease, it's got to be one of the top 5 complaints we hear every single day behind the counter. But here's the thing. While it seems pretty straightforward, there's a ton of complexity hiding just beneath the surface. And your role in uncovering that, it's absolutely critical. So welcome to The Explainer. Let's get right into it.
Okay, so here's our game plan for the next few minutes. We'll kick things off by defining the disease, then we'll get into the why behind it by looking at the tear film. After that, we're going to spend some really crucial time on risk factors, especially drug-induced causes. Then we'll shift into our action plan for assessment and OTCs, and we'll wrap it all up with the most important counseling and referral points.
All right, first up, let's make sure we're all on the same page. What exactly are our patients talking about when they come up to us complaining about their dry, scratchy, just miserable eyes?
So I know this looks like a mouthful. This is the official definition from the Tear Film and Ocular Surface Society. But it's actually super powerful because it immediately tells us we're not just dealing with a minor annoyance. This is a real multifactorial disease. It's about a complete breakdown of the eye's really delicate ecosystem.
So let's just boil that big definition down to what really matters. We're looking at 4 huge problems going on at once. First, a loss of balance, or homeostasis. Second, an unstable tear film that just can't do its job of protecting the eye. Third, hyperosmolarity, which is just a fancy way of saying the tears are too salty. And finally, you've got underlying inflammation that just keeps driving this whole vicious cycle.
Okay, so that's the what. Now let's get into the why. Because to really manage dry eye, we have to understand the structure that's failing, right? And that all comes down to the tear film itself.
You know, the tear film isn't just water. It's this incredibly sophisticated 3-layer structure. Think about it. You've got the oily lipid layer on the very outside, which stops the tears from evaporating too quickly. Then you've got the big, watery aqueous layer in the middle, doing all the hydrating work. And right up against the eyeball is the mucus layer, which basically makes the whole thing stick. A problem in any one of these layers, and boom, you've got dry eye. So this is where it gets really interesting. We can basically split dry eye into 2 big buckets. You have aqueous tear deficient, which is essentially a not enough tears problem. And then you have evaporative dry eye, which is more of a the tears I have aren't sticking around problem. But here's the key. For so many of our patients, it's not one or the other. It's a mix of both.
All right, this next section, this is where we as pharmacists really get to shine. This is where we put on our medication detective hats and start uncovering those hidden clues in a patient's profile.
You know, while things like age and the environment definitely play a role, drug-induced dry eye is incredibly common, and you are in the perfect position to spot it. Sometimes, just a quick glance at a patient's med list can point you right to the culprit that's causing all their discomfort.
And if you look at this list, sure, there's a lot we can't change, like age or sex. But what we can focus on is right there in that modifiable column. And the biggest one on that list for us, it's medications. That's the lever we have the most influence over.
And get this, we're not talking about 1 or 2 obscure drug classes here. We're talking about more than a dozen major drug classes. These are the medications you and I are dispensing every single day. It really puts the scale of this problem into perspective, doesn't it? Okay, so let's name some names. First up, anything with those classic anticholinergic effects is a prime suspect. We're talking about all the common OTC antihistamines, prescription antidepressants like TCAs, and even some SSRIs. They all work by drying things up systemically, and well, the tear film is no exception. And the list just keeps going with some of the most widely used drugs on the planet. Beta blockers, they can actually reduce tear production. And even everyday pain meds like NSAIDs and opioids are on the list of potential offenders.
Of course, we also see it with decongestants, certain hormones, and the classic one, isotretinoin. But check this out, and this is a huge one for us to catch. The eye drops themselves can be the problem. Frequent use of drops with preservatives like benzalkonium chloride can actually be toxic to the eye's surface. It creates this awful, vicious cycle of treating dryness with something that's just causing more dryness.
Okay, so we've identified the problem. We know the potential drug-related causes. Now what do we actually do? How do we assess these patients and help them navigate that totally overwhelming OTC aisle?
These right here, these are your buzzwords. The second a patient says their eyes feel sandy or scratchy, or that it feels like something is in their eye, your dry eye alarm should be going off. And here's a huge clue. Their symptoms almost always get worse as the day goes on.
Now here is a fantastic clinical pearl, and one that might seem a little backwards at first. Sometimes a patient will complain that their eyes are watery, which sounds like the exact opposite of dry eye, right? But what's happening is reflex tearing. The eye is so irritated by the poor quality tears that it just floods the surface with more tears. But they're the wrong kind, and they don't help.
So when you're thinking about management, it's best to think of it like a step-by-step ladder. You always start with education and lifestyle changes. If that doesn't cut it, step 2 is our world, the OTC ocular lubricants. Prescription therapies and other procedures are further down the line and they need a referral, but it's really good for you to know that they're options.
All right, this slide is basically your survival guide for the eye drop aisle, because we all know not all drops are created equal. For viscosity, thicker gels and ointments are great, but they're really best for nighttime since they can blur vision. For preservatives, just remember the simple rule. If they're using it more than 4 times a day, go preservative-free. For osmolarity, hypoosmolar drops are a great choice to counteract those salty tears. And finally, if you suspect evaporative dry eye, look for drops that have lipids in them to help stabilize that outer layer. Okay, let's bring it all home. In our last section, we're going to talk about the key counseling points you need to hit, and just as importantly, the red flags that tell you it's time to refer a patient on. These are the simple, high-impact tips you can give to pretty much every patient. Just reminding them to actually blink when they're staring at a screen is huge. Lowering their computer monitor helps a lot too. And recommending wraparound sunglasses for outdoors, that's such an easy win to protect their eyes from wind and dust. And finally, knowing when to escalate care is a critical part of your job. If a patient isn't getting any relief after a few days of trying the right OTC therapy, if their symptoms are actually getting worse, or if you suspect the drops themselves are causing irritation, it's time for a referral. Don't ever hesitate to send them to an eye care professional. So I'll just leave you with this thought. The next time a patient casually mentions their tired, scratchy eyes, take that extra 30 seconds. A quick look at their profile could uncover that hidden cause and make all the difference for them. So, whose dry eye are you going to solve tomorrow? Thanks for joining this explainer.